Good afternoon, everyone. I'm Loretta Hoffner. I'm the Executive Director of the Maryland chapter of the American Academy of Pediatrics. It is my pleasure to welcome you to today's second session in our three-part series about lead, asthma, radon, and healthy homes in Maryland, new resources for clinicians and patients. Today's session number 2 will discuss an overview of Healthy Homes' approach to children's health. And our presenter for today is Dr. Clifford Mitchell, who's Director of the Environmental Health Bureau of the Maryland Department of Health. Just a side note or a housekeeping issue, those of you who are attending today's webinar will be contacted by my office in regards to getting your CME or Certificate of Attendance credit. So with that, Dr. Mitchell, it's your webinar.
Thank you very much. And can you hear me, Loretta?
Yes.
Very good. Well, I'm delighted to be here with you today to have the second in our series on lead, asthma, radon, and healthy homes in Maryland, new resources for clinicians and patients. I want to thank at the outset Green and Healthy Homes Initiative for hosting this webinar, the Maryland chapter of the American Academy of Pediatrics for its work with us at the Maryland Department of Health to put on this webinar and make new information available to all of you on what Maryland is doing to address issues of environmental hazards in the home. As we proceed, at the conclusion of this presentation, our hope is that you'll be able to identify changes in Maryland law and regulation that reduce blood lead levels in a child, that you'll understand recent trends in the state for lead levels, blood lead testing rates, and that you'll be able to identify and access services on a variety of home-based pediatric environmental health hazards, including lead, asthma, and radon. And finally, identify and be able to access services related to home-based environmental health hazards. As I mentioned, this is the second of our three webinars. In the first, I've really focused on lead and talked about new laws and regulations. And that presentation is going to be available, if you have not seen it already, on video through our website at the Department of Health. Today, we'll focus on a number of other issues. We're going to look overall at children's health and healthy homes. We're going to look at the epidemiology of children's health and healthy homes. We're going to talk about specific environmental health hazards associated with home environments, including lead, but also asthma, radon, and injury. And then finally, we're going to talk about new resources that you can, as clinicians and healthcare providers and other providers, can access in order to make use of these services to improve health outcomes for your clients and patients. And then finally, our next presentation in 2 weeks will be related to case presentations on lead and asthma and how these services and these interactions with the public health system and primary care can lead to better health outcomes for children. I have no conflicts to disclose. And so let's move on and start with a look at how to think about a community-centered medical home. So at this point, Candace, can you put up the first poll? Okay, so what statement most accurately describes your clinical experience dealing with children's environmental health issues like lead, asthma, and radon? Do you find there's no effective way to address most of these challenges unless the family fixes them themselves? Do you find that clinical practice or healthcare organization that you work with has programs that will deal with these issues? Or do you feel comfortable that you can access public health resources to assist your clients and patients who are dealing with environmental hazards? And we're just going to take a minute to sort of help people sort this out, and we'll look at the results. As you're doing that, I do want to emphasize that the whole purpose of what we are doing here in Maryland, as I will describe, is to make more resources available to you and your organizations to help address these issues, which can be challenging, but which I think working together we can address quite seriously. So we've got about 22 people who've now answered. I'm going to give 10 seconds more. So jump on those buttons quickly if you want to. And so Candace, I'm going to end the poll and share the results. And as you'll see, 59% of you feel that the clinical practice or your health care organization does have programs to help families deal with home environmental hazards. And only 4% of you feel that there's no effective way other than the family to fix these themselves, while the balance feel comfortable that you can access public health resources. And this is actually very welcome news, I think, but we're going to now concentrate on making more of you aware and comfortable that you can access public health resources for these purposes. So this model of a community-centered medical home is really intended to show you what the public health infrastructure of Maryland is attempting to do to create a condition in which families with lead or asthma or other home health hazards are really at the nexus of a series of healthcare providers and others involved in care who should be, and we hope will be, working together to address these challenges. And they include managed care entities, local health departments, our state health department, our partner agencies, including the Departments of Environment, Housing and Community Development, and Human Services, and the Department of Education, as well as not just the primary care community, but also pharmacies and school health. If you look at all of these together, the goal is, and I think we are very much focused on creating an evolving approach to healthy homes here in the state. And that approach is characterized by these 4 elements. First, a recognition that physical environment of the home can and does promote a healthy childhood. So it's not just about avoiding illness, it's not just about avoiding injury, it's also about health promotion. Secondly, we are working with families through home visiting, education, provision of materials to help them in their homes, and other resources that will help them identify and abate hazards within the home environment. Third, this is a multi-agency coordinated approach, and as I mentioned, it works with the Department of Health, Environment, Housing and Community Development, Human Services, the Department of Education, and local health departments all together to do a comprehensive approach that also involves ancillary care providers, pharmacists, and others. And as important is the idea that the home really should be addressed as a totality. It's not just a program about lead, it's not just a program about asthma, it's not just a program about radon, it's a program to address all of those in a comprehensive and holistic way so that we have a holistic approach towards these hazards. So in thinking about this, there are several categories of hazards that we are really focused on. First, we are looking at the chemical environment, and that includes things like lead, asbestos, mercury, and other materials and chemicals that are part of the home environment, either intentionally or because they're brought in, or accidentally because they are part of the environment in which the home is constructed. They may include building materials, paints. They may include things that come into the home like toys or food. And so we want to look at those. Pesticides are an important category of hazard, which often overlooked, but can, both by their specific ingredients and also the so-called inert ingredients, also cause adverse health effects. And as you know, childhood poisoning, especially for young children, as well as in older ages, occasionally, unfortunately, related to suicide, are very preventable injuries. Volatile organic compounds, which are emitted from building products and furnishings, can also contribute to asthma attacks. Carbon monoxide, tobacco smoke, other chemical and hazards will also irritate the airways of asthmatics. Second group of hazards that we'll discuss will be physical hazards, and those include radon and other radiation, although we'll focus on radon today. But I don't want to neglect falls, electricity, and the hazards associated with electrocution and fire, because as you know, we lose many children nationally and here in the state, both to fire and to electrocution. And then finally, biological hazards, and those would include allergens, mold, things like that. So to begin with, let's start by talking about the epidemiology of children's health. So starting with asthma, this is a map showing county rates for physician diagnosed asthma, and these are prevalence rates. So these are based on the Behavioral Risk Factor Surveillance System data from 2018. And as you can see, those rates vary tremendously by geography. I do want to point out that if you look at this map at a census tract level, you can see additional disparities and inequities and variation in geography. So these large sort of area maps of county-specific prevalence rates are not fine-grained enough to show. Oftentimes, asthma can be associated with urban areas, with housing conditions, and it should not be ignored at this point that, as we'll point out in a minute, that the disparities and inequity in asthma are very much related to both housing and other social circumstances in which families find themselves. Now, an epidemiologic note here is that if you look at emergency department visits from 2014 to 2017, I point this out to you because many of you will have looked at these and wondered at the discontinuity between 2015 and 2016. That discontinuity is related to the change from ICD-9 to ICD-10, the International Classification of Disease. And because of those changes, which as hospitals' coding systems moved from ICD-9 to ICD-10, it caused a significant change in the rate and number of children and adults who were diagnosed with asthma as a primary condition. So it is important, as you look at these data, to note that these rate changes are not because we have many more children or adults with asthma. It's because we have seen a change in the way asthma is defined and classified in the International Classification of Disease. And so it's very difficult to interpret that transition from 2015 to 2016 other than by simply indicating it as a discontinuity. Similarly, you can see that same impact here. And so just to be wary about this age-adjusted rate per 10,000 for hospitalizations from 2014 to 2017, this does not represent a change in actual asthma experience in the state. Rather, it is another artifact or another thing related to the change in the way those are classified. So I mentioned disparities, and here I want to point out to you the really startling disparities that still exist in asthma rates in Maryland and in the country. These are, first of all, US data. And here what I'll point out, the graph here on the left is a graph of crude percentage of current asthma for US children under 18 from 2015 to 2018. So this orange line at the bottom represents Asian single race. This next line is white. This brown line is Black or African American and white mixed race. And the green line here is Black or African American as a single race. This points out dramatically the significant disparity in the US for Black children versus white children and Asian children as it relates to asthma. On the right here, you see 2015 to 2018 data for children or families living in poverty. And what you see is for those children in the red line at the bottom who are not living in, not considered poor, compared with the blue line, which is considered children living in poverty, or and the green line, which is the near poor. Again, a significant disparity in that helps to explain that significant disparity that we've observed in other settings. Here in Maryland, again, unfortunately, we do experience, again, disparities. And if you look here, you will see this is the rate for 2016 in dark blue, 17 and 18 for emergency department visits by race and ethnicity. And as you can see, the rate for Black non-Hispanic children, sorry, this is overall, for Black non-Hispanic Marylanders is almost 6 times that of the rate for white non-Hispanic, other non-Hispanic, and even Hispanic children who do have a slightly increased rate compared with white non-Hispanic. But this dramatic difference illustrates the significant disparities in Maryland's children and families with respect to asthma. So pivoting, I spoke last time about lead, and I just wanted to, for those of you who were not present, go back to lead to show you the significant increase, significant decrease in children with an elevated blood lead level of 10 micrograms per more per deciliter from the early 1990s, this is 1993, all the way to 2019. And what you can see that is that as the number of children tested annually has increased from 61,000 back in the early 90s to about 132,000 in the most recent year for which we have data, 2019. If you look at the number of children and the percentage of children with elevated blood lead levels, we've continued to see declines in both the mean lead level and the number of children with elevated blood lead levels over the course of this period. it's really a dramatic success story for how well Maryland has done in helping to address lead poisoning, most of which historically was related to lead paint. This is a slide that illustrates again this red line, the children with blood lead levels greater than or equal to 10 micrograms per deciliter. And this indicates the number of children tested. And in our most recent year, what's happened is we've seen that since about 2010 or so, we've continued to hover around a couple of hundred, somewhere between 200 to 300, maybe sometimes north of 300 children per year with newly diagnosed elevated blood lead levels of 10. And at the same time, in the past year, as I discussed our last session, we have just in Maryland last year redefined an elevated blood lead level as 5 micrograms or more per deciliter rather than 10. And what that means is, although we've got somewhere between 200 and 300 cases of children with elevated blood leads of 10 micrograms per deciliter or more, we have about sometimes 4 to 5 times that number who have blood lead levels of 5 micrograms to 9 micrograms per deciliter. Now those children too are also considered lead poisoned, and that, as I mentioned last time, changes the dynamic for how we think about the needs for lead interventions. I also mentioned this last time, that we've seen a transition from most of the lead that's identified coming from lead paint or lead dust in older areas that were considered at risk previously in the 2004 lead testing and lead risk definition, compared with areas that were not considered to be at risk because their housing was newer or for other reasons. If you look at the pattern of sources that can be identified in cases where children are lead poisoned but residing in areas that are not considered previously at risk, those sources are much less likely to be lead paint and lead dust, although they still account for a significant fraction. But jewelry, hobbies, and then spices, cosmetics, and recent arrival to the US as immigrant children, that actually is much more likely to be the source, if a source can be identified, in areas where there is not historically a lot of lead paint or as much lead paint. And just to point out, as I mentioned before, that we are doing a significant amount of effort to try to address lead, and that includes making it easier to do point-of-care testing, which was accomplished by a change in regulation in 2015, and then through a regulatory change in 2016, testing all children, or requiring testing for all children in Maryland at ages 12 and 24 months, no matter where they live. And that has caused, as you can see, between those two things, an increase in testing rates from under 50% to, in some cases, over 50% of testing for children under at ages 1 and 2. But I do want to emphasize there are still many children who are not tested, and we are still looking at ways to improve testing rates. So part of what we're doing is working with the Department of the Environment as it implements the Maryland Healthy Children Act. And part of what we're doing is working closely with them to be sure that we are notifying and informing healthcare providers about new testing requirements, new requirements in regulation for additional information to the blood lead test requisition, including things like Medicaid ID. And those things that we are doing are a way of increasing physician and healthcare provider awareness of lead. And I do want to mention at this moment, obviously, with COVID, it's been very difficult, I know, for many healthcare providers and many families to address home environmental issues because it's been very difficult for families to address anything. We do anticipate that as we progress through this year and into next year, we are going to see significant return to more customary well child care. As part of that, we anticipate that there will be some deferred care that will need to be addressed and deferred issues related to the environment that will need to be addressed. So we're looking forward to working with the clinical community to try to address those issues. So, as I mentioned on July 1st of last year, it is now the case that if a child in what's called an affected property, which is a rental property built prior to 1978, if there's either a child under age 6 or a pregnant woman with a blood lead level that is greater than or equal to 5 micrograms per deciliter, then the Maryland Department of the Environment will notify the owner, the local health department, the healthcare provider, and it's the duty of the healthcare provider, it's the duty of the owner of that property, that rental property, needs to be confident about whether or not that lead could have come from the property, and if so, needs to fix that property. So we'll talk a little bit about that. We talked about that certainly last week, or last session. And what I'll say about that at this point is that the Department of the Environment has been working very closely with both the Department of Health and the Department of Housing and Community Development. We'll talk about some of the programs that have been developed as a result of this. But we're certainly anxious and eager to, and I know the Department of the Environment has been very closely coordinating with primary care providers to ensure that these children have appropriate follow-up. Let me just move to one other hazard, which is radon, and talk a little bit about radon levels in Maryland. This is a map which shows radon levels in Maryland by zip code. It's from data collected between 2005 and 2016. And it was provided by a number of private national laboratories that do a lot of radon tests. And what this shows is the average radon concentration in picocuries per liter in homes that have been tested across Maryland. So as we move now, what I want to say about this, just before we move, is that if you look at the distribution of radon, it's important to understand that it is related both to underlying geology, which is why Maryland's eastern shore, the Delmarva Peninsula, which is relatively sandy and it is really at the edge of the ocean, is very different in terms of radon concentrations measured than the Piedmont and Appalachian part of the state into the middle and far west, where the composition of geology is much more conducive, much higher radium levels, and much more radon. So at this point, Candace, if you wouldn't mind putting up poll number 2. Let me just ask, for those of you who are familiar with this, children who are eligible for Maryland's new home visiting program for lead and asthma must be under 6 years of age, be enrolled in the Children's Health Insurance Program, have a blood lead level greater than or equal to 10, and just go ahead and answer this if you can. And we'll give people a few minutes as you're doing that. What we're going to do now is talk about new resources for clinicians and families. And I want to emphasize that these resources are not meant to replace existing programs in managed care organizations or elsewhere, but they are very much meant to supplement them and to provide additional resources for both primary care providers and families to be able to more effectively address these questions. So I'm going to give people a couple more seconds here. We've got 36 people who've responded, and I will go ahead and close the voting. And Candace, if you can share those results. If you look at these, you can see most people, 47%, correctly identified that none of the requirements above is accurate. And we'll talk about that in just a minute. This program, which we'll talk about, is actually available to a large number of children in the state. And it is really an opportunity for you as primary care providers to use the local health departments as an adjunct to your own interactions with families and understand what is happening in your family's homes. So let me move on, and we'll move on to talk about these new programs. The first two of these programs are both created under a project of Maryland Medicaid and Public Health Services in the Environmental Health Bureau, and also the Department of Housing and Community Development. These programs use the Maryland Children's Health Insurance Program to do lead abatement. That's the Healthy Homes for Healthy Kids program, and also have a home visiting program for children with lead or asthma, which is really an nationally innovative program to address these two important programs. Both of these programs were approved in June of 2017 and have been operating since early 2018. So the first program, which is our Healthy Homes for Healthy Kids program, is an expansion of programs that address lead and that are administered out of the Department of Housing and Community Development. And the eligibility for this program is you have to be a child under the age of 19 who is either enrolled in or eligible for Medicaid or MCHIP. And I want to emphasize at this point, they do not actually have to be enrolled in Medicaid or MCHIP. They have to meet eligibility requirements by income. But otherwise, they don't have to be enrolled, although we obviously try to provide them if they are uninsured. We try to make sure that they get insured. So, in addition to meeting financial resource test of being eligible for Medicaid or MCHIP or enrolled, they have to have a recent blood lead level of 5 micrograms per deciliter or greater, and they have to reside 10 hours or more in the property where the lead exposure is likely to have occurred. I could talk a little bit about how this program works. The way this works is the funding, which is provided by the Department of Health to the Department of Housing and Community Development. A Maryland Department of Housing and Community Development, a lead inspector and a contractor will walk through the property in question. What they do is they look for sources of lead when there's a lead poisoned child, and they will, as always with lead risk assessment, they will look at all the potential sources of lead that they can identify and attempt to identify where the poisoning may have occurred and what was most likely to have caused it. So they will use an X-ray fluorescence device to check for presence of lead paint or other stationary lead. They may take samples of spices or toys or something else to test in the laboratory. the goal is as they are walking through, to identify the sources of lead and at the same time develop a scope of work so that the agency, the Department of Housing and Community Development, can understand what would be required in order to abate or fix that lead problem. Once that scope of work is received, the department looks at how much of what's proposed will address lead-related issues. But importantly, and this gets to the more comprehensive approach that we're using now, DHCD, the Department of Housing and Community Development, also looks at issues like safety. Are there missing banisters? Are there other issues that would represent fall risks, and so forth? In that case, what happens is the lead inspector will identify all of those resources, and when DHCD, the Department of Housing and Community Development, gets that scope of work, they'll look for other funding sources to address those non-lead related issues, so that they can provide the family with as much financing as they are entitled to be able to abate those problems and fix them. Our second home visiting program, and I should mention with respect to the other program that it also will in fact pay for relocation of children while the lead work is going on, if it is sufficiently large that it could result in accidental lead poisoning. Our second visiting program is the home visiting program for children with lead or asthma. This is a program that was previously operating in a couple of jurisdictions, including historically Baltimore City, St. Mary's County, and others. It was operated by local health departments, or in some cases, hospitals or health systems. And the goal is to identify and reduce environmental triggers, as well as make sure that medical management is being understood in the home the same way it's being described in the office. And as I mentioned, it's conducted by case managers and community health workers. These are the 9 jurisdictions. And the criteria here are very similar to the criteria for our Healthy Homes for Healthy Kids program. The child must be under the age of 19, enrolled in or eligible for MCHIP, the Children's Health Insurance Program, live in one of these 9 counties, and have a diagnosis of moderate to severe asthma and or a blood lead level of 5 micrograms per deciliter or greater. As you see, this home visiting program involves a team that will go out and do an initial assessment. Once the child is enrolled, there's an initial conversation that deals with what is the problem. Is it asthma? Is it lead? And then describe to me how your child's lead or asthma problem exists. How are you controlling it now? What medications are being used? What's your understanding of the triggers that have caused this or continue to cause it to worsen? And we do, with the community health workers, a combination of 3 to 6 home visits to look in detail at those environmental health hazards, provide education, and then work with the family and provide mattresses, pillow covers, cleaning supplies, integrated pest management supplies, up to and including a HEPA vacuum cleaner. And the goal of the program is to reduce triggers, but also to foster improved communication and understanding of how health is being experienced in the home to the healthcare provider through the local health department team. Now, I mentioned that we were also considering issues related to injury, which are very important. This, for US children ages 2 to 18, shows the top level of, the top number of non-vehicular related deaths occurring by injury in the United States as a whole. And as you can see, drug poisoning, fire and flame, suffocation, including carbon monoxide, obviously, and falls are all very common and prevalent causes of fatality in children age 2 to 18 in the United States as a whole. So one of our goals as we do our inventory for our home visit is to look for those hazards and make sure we address those as well as the lead and asthma issues. So, so the benefits of this home visiting program really do relate to the ability of the provider and the family to have both an intermediary and an informed intermediary in the form of the local health department who can collect detailed information on the home environment, who understands asthma and certified in asthma education or been trained by people who are certified in asthma education, who know how to look at medication and medication usage. The goal is certainly not to provide medical input in the home environment because that really is the role of the primary care provider, but the local health departments do very much act to help coordinate through asthma action plans, through discussions, to make sure that these issues are being resolved. And so the goal is to have this team, this multidisciplinary team, and as this multidisciplinary team goes into the home, assesses the home, it's also collecting these data in a systematic fashion, and our goal is to make sure that the information collected gets back to the primary care provider so that the primary care work with the family by understanding the context in which the child's condition takes place. So it really is an opportunity for the local health department to be involved dramatically in these in the care of the child in concert with other care providers. So how does one access these programs? So if you're a primary care provider, you can call us. Our toll-free number, we'll say at the end, is 866-703-3266. And our email box, which I'll also show you at the end, is mdh.healthyhomes@maryland.gov. And we'll take referrals from any source, whether it's a clinical source, primary specialty care, whether it's an administrative source like a managed care coordinator, whether it's an emergency department. We will accept all referrals to try to improve health outcomes for this for these children. So if you look at the outcomes associated with our interventions, these are some early data. I will point out, obviously, it will not come as a surprise to you that due to COVID-19, the data we anticipate for this previous fiscal year will be, or current fiscal year, will be different than normal. But what you can see here in this slide is that the hazards that were enrolled, that were identified, did sort of match the traditional pattern of a lot of lead paint, a lot of lead dust, and then we looked at things like soil and lead in water and found much less of that. So it's just pointing out overall that lead paint continues to be a significant problem in the state as a whole. Similarly, if you look through the number of units that have been scheduled for abatement, we have seen a year-over-year increase in the number of units that have been scheduled. And this year, we are continuing to increase, although again, COVID has made it more challenging for us to enroll families in a program that sometimes forces them to be out of their home if there's a lot of lead in the home. That's even more challenging when you're talking about COVID. If you look at our other home visiting programs, and then you look at what kinds of hazards we've identified for children who are either children with a diagnosis of asthma or a diagnosis of lead poisoning, what you can see is that a majority of hazards identified, 87% in children with asthma, 87% of them had triggers recognized in their homes. But also, in children whose primary diagnosis was lead, we also identified 69% of those homes had asthma triggers. And the importance of this goes back to what I mentioned before about treating the home as a whole, as a totality, and not looking just at one type of hazard, but at all types whenever we go into a home. We identified air quality issues. Secondhand smoke was practically the same, whether the child's complaint was asthma or lead. But if you look at things like chipping, peeling paint, there's a huge distinction between the number of homes of children with lead poisoning that have chipping, peeling, flaking paint, and those with children with asthma, in which it was only 1 out of 5. And you can see similarly differences in terms of improperly applied pesticides. Here you can see that in FY20 Q1 compared with Q4 of the previous year, an increasing percentage of children reported, or their parents reported, fewer nights awakened, fewer days with shortness of breath and wheezing, fewer days with use of a rescue inhaler, and even more children with an up-to-date asthma action plan, all of which are metrics and goals associated with our interventions. So as we sort of wrap up, let's see poll number 3, Candace. So your patient tells you that their finished basement in their home has a radon level of 10 picocuries per liter, and you should suggest one of the following: either sell the house immediately, encourage the patient to enroll in smoking cessation, retest the home, or tell the patient to install a radon mitigation device. I expect we'll see a number of various answers here, but clearly most people are favoring either retesting the home or telling the patient to install a radon mitigation device. Only a few are encouraging the patient to enroll in smoking cessation. So I think that we're still pretty evenly split between the installing a radon mitigation device and retesting the home. So I'm just going to go ahead and end the polling. And Candace, if you would share the results. As you'll see, most people, 63%, favored retesting the home, which is the correct answer, as we'll go through in a minute. And the next most common was to tell the patient to install a radon mitigation device, which you could do, but ordinarily, as you'll see at that level, it might be useful to make sure that the test was, that you completely understood the test results. So I'll stop sharing the results and move on to talk about radon. You know, when you talk about radon, obviously you're talking about radiation and a long-term cumulative risk associated with alpha particles that are inhaled into the lungs as a result of inhaling radon gas. And so this schematic shows you the decay from uranium through to radium, and then the immediate next decay product of radium-226 after an alpha emission is radon-222, which has a half-life of 3.825 days and is itself an alpha particle emitter, which, as you recall, is a helium nucleus, 2 protons and 2 neutrons. And so the significance of radon, I really want to commend to you this booklet from the Conference of Radiation Control Program Directors called Reducing the Risk from Radon Information and Interventions, and it's a guide specifically for healthcare providers. So if you look at cancer mortality in 2018, if you look at lung and bronchus cancer, cancer of the lung and bronchus, that was 154,050 deaths. But if you look at radon-induced lung cancer, a subset of that, those 21,100 deaths are important to understand, because radon, after tobacco smoke, is the most preventable form of lung cancer that we know of. And it is and so if you can control and remove radon as a hazard, you decrease lifetime risk of lung cancer for people living in that environment. Maryland has been working, the Department of the Environment, the Department of Health have been working with the United States Environmental Protection Agency through a state indoor radon grant to offer reduced cost test kits available on MDE's radon page, or by calling us at the Department of Health or sending us email. These test kits are done by analyzed by a national laboratory, and they provide a way of assessing your home for radon. The test kits are helpful because they go through the steps of doing the test, how to do the test, and what to look for. We are, as we get more data about radon, we're also using those data through our environmental public health tracking portal to inform people about radon risks and to help. And we're working with our Maryland Cancer Program, the Center for Cancer Control and Prevention, to focus on radon and messaging around radon as a way to reduce the burden of lung cancer in the state further. So we've developed some outreach materials which are available on our website. These go through not only what is radon and why it's important, because oftentimes, as you know, it's very difficult to know. Many people view radiation as exotic, and sometimes it's very confusing. And so this is a way of helping people to understand both the risks of radon, also the importance of testing, and the fact that it is a hazard that can be abated by relatively simple and inexpensive techniques. Those include both after the fact mitigation, so that if you find radon in an occupied home and there's no mitigation, it is possible to vent that radon fairly easily. But there's also radon-resistant new construction, which can help prevent the problem at the outset. So in terms of how to communicate with your tests, communicate the test results to your patients, these are some guidelines which relate to our poll question. For radon levels less than 2 picocuries per liter, you don't need to do anything else at that point. You should be pretty confident, but it's important to remember radon gets into a basement and into a home basically because it finds a way to seep in through cracks or other structural abnormalities or defects in both the slab and the walls. So if you install a sump pump if you develop a crack in your foundation, if you change and do construction in your basement, all of those things can cause even microscopic cracks, which can allow infiltration of radon. Now, it is relatively easy to do this test. And if you do identify radon, it is easy to fix those problems, usually by venting the radon, also sometimes by sealing the cracks and then venting. If your radon level is 2 to 4 picocuries per liter, you should consider retesting your home every 5 years, or if home conditions change, as I mentioned. And if your level is 4 picocuries per liter or more, it's generally advised to do another test just to confirm the results, because it is important to remember and to communicate with your patients that this is not an acute hazard. It's one that takes a long time to develop, and it takes a long time to develop illness. So it's not an emergency. It's something that should be verified and then mitigated. So as we wrap up, what are the take-home messages for clinicians about environmental health hazards in the home? First is, as I said, the home can promote health through a strong, healthy family, but it also has hazards that need to be identified and addressed. The state of Maryland is expanding resources for clinicians and patients to improve housing conditions that can affect children's health through the home visiting programs, through lead paint abatement services at no cost to the family, through the Department of Housing and Community Development, through low-cost radon testing, and other resources that seek to strengthen the ties between primary care providers, healthcare organizations, and public health to address these important issues. And if we can do that, then we will achieve our goal of creating a community-centered medical home where families can be confident that living in their homes, they've done what they can and what they should to address these environmental hazards and produce happy, healthy, long-lived children. With that, I'll stop and turn it back over to you, Loretta and Candace and Chevelle, to see if we have any last questions in the last minute or so.
I guess I will end by saying thank you, Dr. Mitchell, for your wonderful presentation today. I've typed into the chat box that attendees will be contacted regarding CME or certificate of attendance credit. I've also included my full name and contact email address for you. I think you had 1 or 2 more slides, Dr. Mitchell, didn't you?
Yes, I have some additional resource slides. Sorry, I will put those up. And those slides will be available. And as Loretta said, we will also post these slides. But I want to emphasize that we have both at the Department of Health and at the Department of the Environment email addresses, websites, and phone, and we are happy to hear from you always with respect to these challenging questions. And finally,
and with that, I was going to say, if any of you came in.
And finally, just to acknowledge, again, thanks, Loretta, to acknowledge the Maryland chapter of the American Academy of Pediatrics, Dr. Paul Rogers, emeritus member, and the Green and Healthy Homes Initiative, and our colleagues at the Department of the Environment and the Department of Housing and Community Development.
All right. Thank you for that. Sorry. And the last thing I was going to say is if you came in late on this 12 noon session, we are having one today at 5 p.m. If you found this session valuable, please tell your colleagues. There's still time to register for this afternoon's 5 p.m. webinar as well. But with that, I will say thank you very much for attending. And we hope to see you for session 3 on March 23rd.
Thank you all.
All right. Ending the session right on time at 1 p.m. Thank you, Dr. Mitchell.
Okie dokie. Thank you all. Thanks, Loretta, for the reminder that I had a couple of resource slides. That's great.
We'll see you at 5.
See you
at
all at
5
5.
p.m.
Get some lunch.